Hello, and welcome to this weekly Pelvic Perineal Literature Watch for June 5th, 2026, presented by Erwan Lerumeur, physiotherapist in Paris. This is for information only, not individualized medical advice. References are available in the description. This week, the watch retrieved 200 articles. The selection is particularly rich with several randomized trials, systematic reviews, and clinically useful studies on pelvic floor rehabilitation. The editorial line today is simple. Rehabilitation is not just about prescribing contractions. Its effectiveness depends on the exercise content, but also on dosage, feedback, context, age, digital support, access to care, patient goals, and real long-term adherence. We will discuss pelvic floor apps, postpartum care, urinary incontinence in older women, biofeedback, pelvic yoga, menstrual pain, dysenergic defecation, fecal incontinence, female sport, male pelvic health, artificial intelligence, and the organization of pelvic floor rehabilitation in France. First section, top stories. Digital tools are not enough. Adherence has to be built. The most structuring paper this week is by Cristóvão Lind et al., published in International Urogynecology Journal. It is a mixed method systematic review and meta-analysis on digital pelvic floor muscle training interventions during pregnancy and postpartum. The topic is very current. Apps, web-based platforms, reminders, and remote programs are increasingly used. The idea is attractive: improve access, reduce travel constraints, and support home practice. But the clinical question remains, does it actually work, and for whom? The authors included 18 studies involving 4,916 participants. The result is nuanced. During pregnancy, digital PFMT, meaning pelvic floor muscle training, was associated with reduced urinary incontinence. In the postpartum period, effects were mixed, with no clear pooled effect and substantial heterogeneity. The qualitative component may be the most useful part for clinical practice. The authors identified 5 major determinants of adherence: knowledge and confidence, emotional and contextual demands, healthcare communication, sociocultural influences, and program usability. The practical message is clear. An app may contain the right exercises and still fail if the woman does not understand what she should feel, lacks feedback, is exhausted, receives poorly designed reminders, or cannot fit the program into real life. Conversely, digital support can help when it increases capability, opportunity, and motivation to practice. The second key paper is by Hao J et al. In Archives of Gerontology and Geriatrics. It is a systematic review on physical therapy for urinary incontinence in older women. 20 trials were included with 2,002 women across 13 countries. Interventions included PFMT, bladder training, yoga, Pilates, general resistance training, electrical stimulation, tibial nerve stimulation, and multimodal programs. The meta-analysis showed that PFMT significantly reduced urinary incontinence severity compared with usual care, with a standardized mean difference of -1.27. Multimodal programs combining PFMT with mobility, strength, or fall prevention training were also beneficial, with a standardized mean difference of -0.98. This paper is useful because it places urinary incontinence inside a broader functional profile. In older women, we are often not treating leakage alone. We are also dealing with reduced mobility, loss of strength, fear of falling, reduced independence, and sometimes difficulty following complex programs. PFMT remains central, but it may work better when integrated into a broader physical therapy strategy. The third paper in this top section is by Noordin N and Justine in the Journal of Taibah University Medical Sciences. It analyzes a physiotherapy-led integrated care program called PTICOPE in older adults with overactive bladder symptoms and difficulties in instrumental activities of daily living. The urinary result is negative. After 12 weeks, the program did not significantly improve overactive bladder symptoms or instrumental activities compared with usual care, but this negative finding is useful. It reminds us that a multi-domain program, even when well-designed, may not be enough to improve urinary symptoms if the bladder-specific component is not targeted, dosed, and monitored enough. Together, these 3 papers set the frame. Digital support can help. Physical therapy works in older women, but programs that are too general may miss the target. The challenge is to combine access, specificity, progression, feedback, and adherence. Second section, postpartum care. Prevention, access, and sorting out techniques. We start with Jin Z et al. In the African Journal of Reproductive Health. The authors report a randomized trial in 110 primiparous women. Comparing Kegel exercises alone with Kegel exercises plus acupoint application at Qihai and Guanyuan. At 42 days postpartum, the combined group had a lower rate of urinary leakage, better type 2 pelvic floor muscle strength, better CIQSF scores, and improved anxiety scores. There were no significant differences in type 1 muscle strength, vaginal dynamic pressure, PFD I-20 scores, or bladder and cervix anatomical position. Adverse effects were minor, with 2 cases of local redness or itching. The useful point is not to turn this paper into a direct recommendation for acupoint application. The interest is that a postpartum program can be structured, early, tolerated, and evaluated on several dimensions: leakage, strength, symptoms, anxiety, and anatomical criteria. The limits are clear: short follow-up, culturally specific protocol, and need for independent confirmation. The second postpartum paper is more decisive. Santos Vanzella, Fitz, Aquino Castro et al. In International Urogynecology Journal published a systematic review and meta-analysis on far-infrared radiation and low-level laser therapy for pain and healing after childbirth-related perineal trauma. 9 studies were included and 5 entered meta-analyses. The results showed no clear added benefit of far-infrared or low-level laser therapy over conventional approaches, either for pain or wound healing. Laser versus placebo or sham therapy showed no significant difference at 20 to 24 hours or 40 to 48 hours postpartum. Far-infrared radiation also showed no significant difference compared with no treatment or sitz baths. This is clinically useful because it tempers enthusiasm for appealing physical technologies when evidence remains weak. In postpartum care, priorities remain proper assessment of pain, wound healing, continence, anorectal symptoms, sexual difficulties, and functional recovery. Technology does not replace clinical examination, clear information, and follow-up. Still in postpartum care, Riche, Poquet, Grandemange et al. In International Urogynecology Journal used the French National Health Data System to describe pelvic floor rehabilitation practice and costs in France. In 2022, 638,982 women aged 18 to 65 received pelvic floor rehabilitation. 58.7% were postpartum. The average number of sessions ranged from 6.6 to 14.9 depending on the pathway and was described as below recommended levels. Overall, pelvic floor rehabilitation generated 4.8 million consultations and cost 114 million euros. This paper is particularly relevant for France. It shows both the scale of pelvic floor rehabilitation and the diversity of care pathways. It does not provide clinical outcomes because it is based on administrative data, but it describes real-world practice, many sessions, variable pathways, and likely gaps between needs, prescriptions, practice, and outcomes. Another postpartum access paper, Postpartum Physical Therapy Utilization, among low-income patients in San Diego, published in Urogynecology, reports low referral rates to postpartum physical therapy in a medically underserved population with ethnic disparities. Hispanic patients were referred less often than other groups. Adherence was also influenced by age, pain, education, and social factors. This is a United States-based study and should be transferred cautiously. Still, it makes an important point. Adherence starts before the first session. If women are not referred, if access is difficult, or if cost, language, transportation, or family burden interfere, the best rehabilitation protocol remains theoretical. Third section, pain, dysmenorrhea, and modulation. Choosing what we test. The week is also rich in pain-related papers. Collet-Luceregi, Demir, Enish et al. In the Journal of Bodywork and Movement Therapies evaluated a pelvic floor-centered education program in 66 young women with primary dysmenorrhea. The intervention involved multi-component education and a brief guided practice session during a single visit, followed by self-care. Outcomes included pain, dysmenorrhea impact, and pelvic floor knowledge. Both groups improved in pain, but the intervention group showed greater improvement in pain and dysmenorrhea impact. After adjustment, pelvic floor knowledge also improved more in the intervention group. This paper is interesting because the intervention was light. It was not a long or expensive program. It suggests that targeted education, combined with short guided practice, may influence pain and functional impact over one menstrual cycle. Longer follow-up is needed, but the clinical signal is relevant. Understanding the pelvis, pain, breathing, relaxation, and self-care strategies may already produce a measurable effect. In the same field, Manriquez, Troncoso, Pasten et al. In the Journal of Pediatric and Adolescent Gynecology published a double-blind, randomized, placebo-controlled trial on transcutaneous posterior tibial nerve stimulation for primary dysmenorrhea in adolescents. 87 adolescents were randomized. One group received mefenamic acid and sham stimulation. The other received oral placebo and active tibial nerve stimulation with 3 30-minute sessions per week for 8 weeks. Now, both groups achieved clinically significant pain relief with no difference between them. The authors conclude that transcutaneous tibial nerve stimulation produced pain reduction comparable with mefenamic acid and could be considered as a therapeutic alternative with the advantages of self-application and no reported adverse effects. This does not mean standard treatment should be replaced, but it is an interesting signal. Some functional gynecologic pain conditions may respond to simple, non-invasive peripheral neuromodulation strategies that can fit into self-management programs. On the bowel side, Büyüktaş, Gülçu, Bakar, and Zeren in the Journal of Manual and Manipulative Therapy compared post-isometric relaxation and pelvic floor relaxation exercises in 42 women with dyssynergic defecation. Both groups received 8 sessions. Outcomes included constipation severity, pain during and after defecation, defecation duration, quality of life, electromyography, sexual function, and pelvic floor impact. Both approaches improved symptoms, but reductions in defecation duration, pain, constipation severity, quality of life limitation, and pelvic floor relaxation activity were greater in the post-isometric relaxation group. Sexual function scores, including total FSFI, also improved more in that group. This is a small trial, but it speaks directly to manual and functional practice. In dyssynergic defecation, the issue is not simply weakness. It is often relaxation, coordination, timing, effort perception, and pain. This paper supports approaches focused on relaxation, coordination, and motor control. Fourth section, biofeedback, constipation, and fecal incontinence. Home-based tools are progressing, but selection still matters. Still in anorectal rehabilitation, Kochar, Chanapragada, Shenoy et al. In neurogastroenterology and motility studied EMG-based pelvic floor biofeedback therapy in patients with constipation. This retrospective study included 208 patients who completed at least 2 sessions. The authors compared patients referred after anorectal manometry and balloon expulsion testing with patients referred directly without prior instrumental testing. Half of the patients achieved successful outcomes. Success rates did not differ significantly between the tested and directly referred groups. Patients in the manometry group had worse baseline symptoms, but manometric diagnoses and balloon expulsion results were not associated with outcomes. The authors conclude that when manometry access is limited, biofeedback may be started based on clinical assessment. This is important for care pathways. Functional testing is useful, but its absence should not always block conservative treatment when the clinical picture is compatible. The opposite risk is treating blindly. The reasonable route is careful clinical assessment, clear goals, reassessment, and escalation to specialized testing if progress is not consistent. For fecal incontinence, Kaiser, Miller, Hosterman et al. In diseases of the colon and rectum reported real-world results of a digital therapeutic device for women. The intervention used an intravaginal motion-based biofeedback device paired with a smartphone app for 8 weeks. 214 users were included, with a mean age of 58.8 years. The mean CRADI-8 score improved by 8.2 points. 58.4% reached the minimum clinically important difference, and 73% of respondents reported global improvement. Device-captured pelvic floor performance also improved. Weekly adherence remained high, and no serious device-related adverse events were reported. The limitations are substantial. No control group, selection bias, patient-reported outcomes, limited diagnostic confirmation, and limited generalizability. But the study fits the same broader trend as Cristóvão et al. Digital tools may expand access, especially when conventional biofeedback is difficult to obtain. The key question remains who uses them, who drops out, who improves, and how professionals integrate the data into care. Fifth section, urinary incontinence, feedback, goals, and quality of life. In postmenopausal women, Shan, Zhu, and Tao, in International Urogynecology Journal, compared PFMT alone with PFMT plus EMG biofeedback in 168 women with stress urinary incontinence. A follow-up was 12 weeks. The combined group showed greater reduction in ICIQ-SF score and greater reduction in 1-hour pad test leakage. Maximum voluntary contraction improved more, and bladder neck mobility decreased more. However, a key detail matters. Although the between-group difference in ICIQ-SF was statistically significant, it did not reach the predefined minimal clinically important difference of 4 points. This is a good example of critical interpretation. Biofeedback may improve objective parameters in some scores, but statistical significance is not enough. For the patient, the meaningful outcome is less leakage, fewer pads, less bother, and more functional freedom. Tool selection should consider clinical benefit, cost, access, time, and patient profile. Wu, Yang, Zhu et al. In World Journal of Urology reported a large national cross-sectional Chinese study on quality of life in 9,974 adult women with urinary incontinence. Most women had slight symptoms and reported good quality of life. Factors associated with poor quality of life included urgency, urinary incontinence, mixed urinary incontinence, moderate or severe severity, advanced age, smoking, chronic constipation, and other sociodemographic or clinical variables. This paper reminds us that leakage amount is not the whole story. Incontinence type matters, constipation matters, context matters, sleep matters, beliefs and avoidance strategies matter. A muscle-only approach may miss a large part of the problem if urgency, bowel dysfunction, or participation restrictions are ignored. Along the same line, Mao, Brown, Lee et al. In Urogynecology studied patient-reported goals of women with urinary incontinence in primary care. Among 2,986 women who screened positive for urinary incontinence, 458 reported treatment goals. The most common goals were symptom relief, 46.1%, and information seeking, 33.6%. Some reported lifestyle or emotional goals, and 15.1% had overlapping goals. Women prioritizing symptom relief were older and had higher ICIQ scores. Those mainly seeking information preferred to avoid procedural interventions. For rehabilitation, this is very practical. The first consultation should not ask only, how much do you leak? It should also ask what the person wants to do again, what worries them, what treatment they want to avoid, and what change would be meaningful. Sixth section, sport, loading, and under-recognized groups. Several papers addressed pelvic health in young or athletic women. Nalda Inostroza Whipple et al. In International Urogynecology Journal studied 366 women participating in the Santiago Marathon. Stress urinary incontinence was reported by 33.9%, vaginal bulge symptoms by 23.5%, pain during sexual activity by 20.2%, and fecal incontinence by 7.1%. Age 35 years or older and parity were associated with stress urinary incontinence. Race distance was not significantly associated with pelvic floor symptoms. This avoids a common shortcut. Longer running distance does not automatically mean more pelvic floor symptoms. Individual factors, age, parity, history, and probably load management matter. In female runners, screening should be practical. Symptoms during effort, protective strategies, training avoidance, heaviness, pain, and sport goals. Bell, Mastwick, Hannington et al. In JSA MS+, surveyed 746 female field hockey players in Australia. 1 in 4 reported some form of urinary incontinence, but only 30% of symptomatic players had seen a healthcare professional. About half of those with exercise-related symptoms did not change participation, but 22 to 36% modified or stopped some activities. Symptoms were more frequent in masters players than in juniors or seniors. The practical message is clear. Symptoms are present, but often not discussed. In clubs, clinics, or sports settings, waiting for athletes to raise the issue spontaneously will underestimate the problem. Simple screening questions and clear referral pathways are needed. Mittal, Siddiq, Sharma et al. In Scientific Reports studied stress urinary incontinence in 233 nulligravid college women. Urinary impact was associated with higher perceived stress, poorer sleep quality, and lower health-related quality of life. Regression analyses suggested that urinary incontinence impact, stress, and sleep all contributed to quality of life. This broadens the lens. Stress urinary incontinence is not only a postpartum or menopause issue. It can affect young women who have never been pregnant, with psychological and functional consequences. Clinically, it supports asking about urinary symptoms in young athletes, students, and women doing impact sports, even if they do not fit the classic profile. Finally, Lara Albin, Cruz Medal, Albuquerque Sendin et al. In International Urogynecology Journal assessed mechanical properties of pelvic floor and lumbar paravertebral muscles in premenopausal and postmenopausal women using myotom PRO. They compared tone, stiffness, elasticity, and viscoelastic properties. This is a small cross-sectional study, so it cannot establish treatment effects, but it points toward a useful direction, measuring tissue and function, not symptoms alone. Future rehabilitation may combine symptoms, strength, endurance, coordination, mechanical properties, and real-life function. Seventh section, Men, Children, Artificial Intelligence and Professional Skills. Male pelvic health is represented by Male Pelvic Health in Saudi Arabia in the Saudi Medical Journal. Amuteri et al. Assessed knowledge, attitudes, and practice of PFMT among 458 Saudi men. General awareness was moderate, 63.1%, but only 13.1% knew how to perform PFMT correctly, and only 11.6% practiced regularly. Attitudes were mostly positive, but practice remained limited. This cross-sectional paper is useful. In men, pelvic floor rehabilitation is still often associated mainly with post-prostatectomy care, whereas it is also relevant to pelvic pain, urinary symptoms, sexual function, anorectal symptoms, and prevention. The gap between "I have heard of it" and "I can do it correctly" is probably large in many settings. In children, von Gontard, Bick, Colisi et al. In Neurology and Neurodynamics examined neuromotor skills in 59 children with nocturnal enuresis or daytime urinary incontinence, compared with 58 continent controls. The starting point is that childhood incontinence may be associated with neurodevelopmental disorders and coordination difficulties. This is not a classic pelvic floor exercise paper, but it reminds us that some continence disorders are part of broader neuromotor organization. In children, working only on the bladder or toilet routine may be insufficient when coordination, attention, motor skills, and behavioral comorbidities are involved. On professional organization, Tien Chen Xie et al. In Nursing Open used the Delphi method to build a core competency evaluation index for incontinence specialist nurses. This is organizational, but it highlights an important need. Continence problems are common, chronic, and multidimensional, requiring specific competencies. Defining those competencies can help structure education, assessment, and care pathways. Finally, Sinar Safran and Ayildiz Eroglu in International Urogynecology Journal tested the effect of persona-based prompting on ChatGPT response quality in pelvic floor physiotherapy. 21 clinical questions were submitted to GPT 4.1, either with a neutral prompt or with a role-play prompt asking it to answer as an experienced pelvic floor physiotherapist. 2 physiotherapists rated the answers. Persona-based prompting significantly improved relevance, accuracy, comprehensiveness, and clarity, with the largest gain in comprehensiveness. This paper is more than a curiosity. It shows that artificial intelligence output depends heavily on how the question is framed. Even with better prompts, accuracy remains imperfect and professional oversight is required. In practice, artificial intelligence can help structure explanations, generate educational material, prepare progressions, or rephrase instructions, but it does not replace clinical reasoning, examination, or responsibility. Last section, the briefs. First brief. Baser, Seeker, and Chelliker-Tosin, in Scientific Reports, evaluated reliability and sensitivity to change of mobility tests in 77 older adults with urinary incontinence. Timed up and go, modified. 4-square step test, 30-second chair. Stand test and 2-minute walk test showed excellent test-retest reliability with ICC values above 0.96. This supports integrating mobility, balance, and function into incontinence assessment in older adults. Second brief. A scoping review in International Urogynecology Journal on intra-abdominal pressure during physical activity showed that measurements are highly variable and depend on sensor type, placement, gravity, acceleration, and context. The authors call for better methodology. This helps avoid reducing pelvic floor loading to a single universal pressure value. Third brief. The French study on pelvic floor rehabilitation practice and costs deserves a second mention. Almost 639,000 women in 2022, 4.8 million consultations, and 114 million euros. Understanding pelvic floor rehabilitation in France will require linking administrative data to clinical outcomes. Fourth brief. The study on patient-reported goals in urinary incontinence shows that goals are not uniform. Some women want symptom reduction, others want information, avoidance of procedures, better sleep, social freedom, sport participation, or reassurance. This is a useful basis for personalized rehabilitation goals. Fifth brief. The studies on marathon runners and field hockey players converge on the same signal. Pelvic floor symptoms are common and underconsulted in female athletes. Physiotherapy clinics can play a simple screening role, especially when athletes modify or avoid specific efforts. Conclusion. This week's papers point to a clear message. Pelvic floor rehabilitation works best when it is specific, dosed, monitored, understandable, and realistically usable. Cristóvão et al. Show that digital tools may reduce urinary incontinence during pregnancy, but postpartum effects are heterogeneous and depend heavily on adherence. Hao et al. Confirmed the value of physical therapy in older women, especially when PFMT is combined with functional training. Noordin et al. Remind us that general integrated care may not be enough without targeted bladder work. Jin et al., Yang et al., Santos Vanzella et al., Kolailu-Chereschi et al., Manriquez et al., Buyuktash et al., and Kochhar et al. Each add a piece of the puzzle: exercise, feedback, relaxation, neuromodulation, education, technique selection, and patient selection. The common point is clear. Effective rehabilitation does not start with a list of exercises. It starts with assessment, indication, goals, progression, and an adherence strategy. Thank you for listening. Always check the full papers and current guidelines before changing practice. References are available in the description. And see you next week for another edition.